to receive her Doctor of Medicine. After residency, she plans to practice primary care. One of her most recent research interests includes examining the use of escitalopram in treatment of anxiety in children with chromosome 18p deletion. Some of her additional experiences during her time here have included establishing a nail salon for patients through Child Life, regularly leading bi-monthly LGBTQ educational workshops for third-year medical students, and active engagement in both admissions for medical students and recruitment of new interns, as well as regularly serving on the Resident Wellness Committee. Thanks for joining us, Hannah.
Thanks for that introduction, Katie. Hi, everyone. Good morning. Thanks for having me. Today, we are going to talk about the safety and efficacy of the 24-hour shift. Let's see. I have no formal disclosures or affiliations. I, however, have some informal affiliations. These are my dogs, Lola the Morkie and Pug the Pug. There's not a lot of good visual aids for this topic, so they're going to help me demonstrate what it sometimes feels like to be a sleepy resident by pictures of sleepy pups. And then I am using Google Docs for this presentation. It's been freezing on me a little bit lately, so it may take a couple seconds for me to transition between slides. So if that happens, just hang tight. Sorry for the potential awkward silences. Okay, so these are the objectives of this talk today. I'm not going to read them all to you, but in a nutshell, we are going to basically talk about the history of duty hours and how 24-hour shifts kind of came to be. We'll talk about how there's a lot of conflicting evidence on if they're good or bad for both residents and patients. And then we will talk a little bit about how there are some alternatives out there and what it means for our program. Okay, so what are duty hours? We know them, we love them. If you're like me, Autumn emails you about them every couple days. And you may have not had them at all during your residency training because they did not always exist. So there's a pretty long history of duty hour regulations. In 1889, the first medical residency program came to be at Johns Hopkins, and residents were required to live in the hospital, hence the term residence. Thank goodness sometime between the 1880s and the 1980s, that practice fell out. Residents no longer lived in the hospital, but there weren't anything like duty hour regulations. So residents routinely worked greater than 80 hours a week. I found a statistic that it typically averaged around 92 to 96, and extended shift work was up to 36 hours per shift, not limited to the 24 like we know. In 1984, I think a lot of you are probably familiar with this case. Libby Zion came in. She was an 18-year-old female who had serotonin syndrome and unfortunately passed away under the care of a resident working a 36-hour shift. It later came out that no attending actually saw this patient. However, an attending was spoken to on the phone. All parties involved were exonerated by the case of law that this was tried in. However, it really brought to light the potentially unsafe working conditions that residents were working under. Something called the Bell Commission was formed, and then they recommended these new rules for duty hours. So after Libby Zion, that's when duty hours really first became a topic of conversation. In the early 1990s, so about 10 years after Libby Zion had passed away, non-standardized rules went into effect in New York, and there were a lot of varying degrees of compliance, especially within the surgical specialties. And then there was really no formal governing body that made these rules something that everybody absolutely had to follow. So in the mid-1990s, ACGME did come in and impose duty hours to specific specialties only. They favored longer hours for surgical residents and still kind of pushed for residents to be working longer hours in the hospital. However, for the next 10 years, the American Medical Association, as well as a group called Public Citizen, as well as a couple other groups, became kind of increasingly angry at the fact that these duty hours weren't being imposed and that they only protected certain subspecialties of residents. They kind of backlashed at OSHA and ACGME. So duty hours were implemented for the first time to all residency programs. There were fines at hospitals if the duty hours were not being followed. And throughout the years, they've been changed according to different studies and different practices that have come to play. So here on this slide, I kind of just show you the 2003 versus the 2011 ACGME requirements. There was another large change in 2017. Something that's been pretty consistent is that the 80 hours averaged over 4 weeks hasn't really necessarily changed. You can see here that the maximum duration of duty hour period has actually changed pretty significantly here. It used to be 30 hours. In 2011, it was 16 hours for interns and 28 hours for more senior residents. And then in 2017, there was another significant change where all trainees were allowed to do 24-hour shifts, including interns. And then the in-hospital on-call frequency is another thing that's monitored by duty hours. You're only allowed to do it every third night, averaged over 4 weeks. That's stayed pretty consistent. And then a minimum time off is 10 hours, needs to be at least 8 hours, and then 14 hours after an in-house 24-hour call. Here I have the current duty hour regulations, which are essentially everything that I just talked about. The big difference that has occurred over the years is that extended call 24-hour shift. We went from 30 hours to 16 hours for interns to now 24-hour on-duty limit with a 4-hour extension for patient continuity and education. So 28 hours maximum in the hospital. And then you have to have on average one 24-hour period per week free of clinical duties. So that's essentially like 1 day off per week. So now we'll talk a little bit about the controversial 24-hour shift. This is a picture of me and Lola after one of my 24-hour shifts. She looks more tired than I do, I think, but again, the life of a dog is very hard. So we have studies dating back to the 1970s that provide a lot of conflicting information about the dangers and benefits of working extended hours in the medical setting. There hasn't really been a formal conclusion based on these studies, and there is still a lot of controversy in the medical field today about if we should do 24-hour shifts and what's the best way to do them. So one thing that we're sure of is that there is a definite effect of sleep deprivation on residents, whether it be acute sleep deprivation or chronic sleep deprivation. Some of the more chronic effects of sleep deprivation from non-standard and late hour work shifts lead to higher risk of GI disorders, cardiovascular disease, breast cancer, depression, preterm birth, and low birth weights of their newborn. So lots of long-term health issues. This is kind of a social issue that I found. Married couples who work continuous night shifts are more likely to get divorced. Men are 6 times as more likely to get divorced than their daytime counterparts, and women are 3 times more as likely. So lots of social implications of working unusual shifts and longer shifts in the hospital. And then continued effective sleep deprivation on residents. I thought this study was really interesting just because of how it was done. I'll talk about it a little bit. I don't know how overly applicable it is to short-term shifts, but there was a study done in 2017 where they looked at people without sleep disorders and people with sleep disorders that interrupt their slow wave sleep. And then they would do LPs on them after a night of sleep. And they found that having disrupted slow wave sleep actually increases your level of amyloid beta protein, which is, of course, a precursor to Alzheimer's disease. There is no study that formally connects lack of sleep or disrupted sleep to Alzheimer's disease, but this study did show that it had the increased level of amyloid beta protein. I thought it was an interesting study. I thought it was interesting the way that it was done, and does show that chronic interrupted sleep does affect the way that your body gets rid of toxins such as the amyloid beta protein. It, of course, can have a negative effect on overall mood. There's multiple studies show that there is an increase in feelings of anger, irritability, and overall sadness. And there are higher rates of motor vehicle accidents after prolonged 24 shifts. There's a pretty famous study that was done that showed that interns are more than twice as likely to have a motor vehicle accident after a 24-hour shift, and then 5 times as likely to have a near miss incident on the road. So pretty significant effects in terms of chronic sleep deprivation and acute sleep deprivation. We're going to freeze here for a second, I think. There we go. So now I want to talk a little bit about the effect of resident sleep deprivation on the patients that we care for. I really like this picture of Pug because it shows the poor decisions that you can make when you're very tired. Here he is sleeping on the floor despite being in the middle of 2 beds. So I would call that some poor sleepy decision making. Sleep deprivation can increase the rate of medical errors. I will talk about that a little bit in the studies moving forward. Chronically sleep deprived individuals actually tend to underestimate their degree of impairment, so they may be giving themselves more responsibilities or more credit for their abilities than they actually have at the time. And then sleep deprived versus non-sleep deprived residents are more likely to perform lower on standardized questionnaires and report lower mood and functioning. One of the more famous experiments that was done in 1970 is they looked at residents' ability to interpret EKGs and notice arrhythmias after working prolonged shifts. And they found that you're more statistically significant to perform poorly after a prolonged shift. There's one study that was done, it's also pretty famous, I'm sure y'all have probably heard of it, that after 24 hours of sustained wakefulness, function is equivalent to a blood alcohol concentration of 0.1%, which is of course significant. And then I thought that this was a pretty interesting study as well. This meta-analysis looked at physicians versus non-physician performance after staying awake for continuous amounts of hours. Staying awake for 24 to 30 hours decreased physicians' overall performance by 1 standard deviation and their clinical performance by more than 1.5 standard deviations. However, this difference in well-rested versus sleep-deprived physicians is less significant than their well-rested counterparts, which basically means that sleep-deprived physicians are consistently performing better than their non-physician sleep-deprived counterparts. The study thought that this was likely a compensatory mechanism for chronic sleep deprivation that's frequently seen in the medical field. So even though there is a difference in performance between sleep-deprived and non-sleep-deprived, sleep-deprived physicians are still performing better than the average population. There was a landmark study done in 2004 that looked at the effect of reducing interns' work hours on serious medical errors in intensive care units. You had and I will warn you now, I looked at a lot of studies that looked at 2 different types of schedules. There's a lot of different verbiage and it's a little bit confusing. I tried my best to clarify it on the slides, but I would just kind of pay close attention to the way that it's written on the slides. It's not always standardized between studies. In this particular study, the traditional schedule was a 24-hour shift every 3 nights, which follows the standard ACGME regulations. And then the non-traditional schedule eliminated extended shifts and decreased the number of hours worked per week. So it's a little bit more protective towards the residents. So this study found that in the traditional scheduled format with the extended 24-hour shifts, there was 39.5% more serious medical errors, 22% more errors in the ICU setting, about 21% more serious medication errors, and 5.6 times as many diagnostic errors. You can see Lola's very concerned about these numbers, as am I. So Pug is wondering, with this knowledge, why are 24-hour shifts still encouraged? Why are they part of ACGME recommendations? So this is where things get a little bit complicated. There's 2 studies that kind of govern the ACGME's decision to continue 24-hour shifts in medical resident education. The one is called the FIRST trial. It's flexibility and duty hour requirements for surgical trainees. This was published in the New England Journal of Medicine in 2016, so it's fairly recent. Like I said, it helps dictate current duty hours because both of these studies didn't really find any statistical differences between resident well-being or patient safety. The outcomes in this particular study included post-operative death or serious complication for the patient. And then when looking at resident outcomes, they included perceptions and satisfaction regarding wellness. So here I talk about the standard versus flexible duty hours that they used in this study. The standard policy group followed the ACGME policies that were set in place in 2011. So interns' duty hours were not allowed to exceed 16 per shift, and then older residents were not allowed to exceed the 24 plus 4 per shift. Whereas in the flexible policy group, their duty periods can extend past that 16 and 28-hour time period. Another big significant difference is that in the standard ACGME policy, residents had to have that greater than 8 hours off between shifts. That was not required in the flexible policy group. Something that did stay the same between the 2 of them is that they worked an 80-hour work week. So the way that the hours were worked was different, but they still only worked a maximum of 80 hours. So this is basically looking at a difference between extended shift work. So in our standard duty ACGME hour group, there was about 9% serious deaths and injuries, which is about the same as the flexible or more extended duty hours. There was also about the same level of dissatisfaction with education, following at about 11%, so no statistical difference there. Something that was a little bit different between the standard ACGME duty hours versus the longer duty hours is that residents were less likely to perceive negative effects of duty hour policies on their personal activities, which makes sense. Their time at the hospital was a little bit more limited and structured, so they were allowed to do more things outside of the hospital. But when you're looking at the flexible or extended duty hour group, they were less likely to perceive negative effects of duty hour policies on patient safety, continuity of care, professionalism, and resident education, which also makes sense because you're staying at the hospital for a longer period of time, you're having less handoffs, you're following patients for a longer period of time. So it's kind of intuitive there that those things go together. Something that was statistically different in the standard versus flexible groups is that there was a higher rate of having to leave the OR during cases and a higher rate of having handed off active patient issues in the standard group, which again makes complete sense because if you're having to leave during an OR case because of your duty hour regulations, and then you're also having to hand off active patient issues because you are not allowed to stay at the hospital to continue caring for this patient as your shift is over. Something important to note is there was no significant difference in perception of fatigue on personal or patient safety, regardless of how long your extended shifts were. A second study that was done is on internal medicine residency programs. It's called the iCompare study. And this again measured both patient safety outcomes and resident outcomes by looking at sleep and alertness. And they looked at, again, the traditional versus the flexible duty hour schedules. Here again, they're fairly similar. This is just a reminder about the flexible versus standard. In the flexible, there were no restriction of shifts, whereas in the standard, they were restricted to 16 and 24 hours. And again, their maximum work hours still maintained at 80, regardless of the group that you were in. I do apologize here. You'll see that the flexible is on the left and the standard is on the right. But when you flip to my slide, the standard is on the left and the flexible is on the right. So just be mindful that that kind of, sorry about that. Just be mindful that that kind of switches here. So here we're looking at patient safety outcomes. The primary outcome that they're looking at here is a change in unadjusted 30-day mortality from the pre-trial year to the trial year. So in the standard ACGME duty hours, there was a 12.2% 30-day mortality. And in the flexible longer duty hours, it was a 12.5%. So no statistical significance. They also did a non-inferiority study looking at 7-day readmissions, patient safety indicators, and Medicare payments. And there was non-inferiority for the flexible compared to the standard as well. So really no statistical significance overall. And then when looking at resident sleep and alertness, the primary outcome was sleep duration as well as morning sleepiness. These were also compared using non-inferiority methods. They looked at 400 residents over a 2-week time period. In the standard ACGME regulated, residents were getting about 7 hours per night. And in the flexible non-ACGME regulated, residents were getting about 6.85 hours per night. This was not statistically significant. They also used the Karolinska sleepiness scale here and only differed by about 0.12 points, which showed that the flexible duty hours were non-inferior to the standard. So again, no statistical difference between patient outcomes or sleepiness in the iFirst trial or this iCompare trial looking at surgical residents and their patients and internal medical residents and their patients. So I know what you're thinking. Tell us about pediatric patients. Well, I will do that next. So there are 2 more recent studies. They are sister studies published in 2020 and 2021. They look at, this one I'll tell you about first, at medical error in the ICU setting, specifically the PICU. And notably, this examines performance of PGY2 and above. Some of the studies that I had talked about earlier looked specifically at intern performance. So this is interesting. We're getting a little bit further in our training in these studies. They looked at the performance via direct observation and chart review. So residents weren't being asked to do any specific tasks after shifts. They were just looking at what happened during their shifts. So the 2 kind of shift work that they did were shifts greater than 24 hours, which again is non-ACGME regulated at this point, but it's more similar to what we do, versus the cycled day and night shifts, which is less than 16 hours. No resident is doing 24-hour shifts. It's more of a night float type pattern. So in the scenario where residents worked longer hours, their average work time was about 68 hours per week versus the cycled, which was about 62 hours per week. The mean patient load was also less during the 24-hour shift time periods. It was only about 6.7 per shift, whereas the mean patient load increased to about 8.8 per shift when you're working a shorter shift time. Residents also slept about 6.4 hours more per week during the cycled shifts. However, the error rate, interestingly enough, was higher in the shorter shift period, which did not follow the hypothesis that the researchers had said at the beginning of starting this experiment. So when you look at the raw data, it shows that having shorter shifts actually increases your error rate, whereas having longer shift is protective against serious medical rates in the ICU setting. However, the researchers adjusted this data for patient load, noticing that you had a higher error rate in the same group where you had a higher patient load. So when you adjusted for patient load, the error rates actually were not increased at all. So this study is basically showing what we've learned all along, that the shift length in and of itself is not increasing the error rate, but it is introducing a new idea that potentially patient load is a factor when it comes to serious medical errors in the hospital. So, like I said, two sister studies. The first one looked at medical error rates, and the second one looked at neurobehavioral performance of residents after these extended shifts. They used a PVT test, which looks at it's a 10-minute test. It looks at your reaction time, and they again use this Karolinska sleepiness scale. Something I learned is there's a lot of different ways to define studies, shift work in these studies. So this one, just to make things extra fun and confusing, used something called the EDWR, which is the 24-hour shifts that we all are used to, versus the RCWR, which is that limited day and night shift to 16 hours. So slightly different language, same concept of the greater than 24 versus the 16 hours. So when you look at the neurobehavioral performance overall, everybody who performed in the 16-hour versus the 24-hour group did better. When you look at your attentional failures, and these were all statistically significant, by the way, attentional failures mean 6.8 when you worked greater than 24 hours, down to 2.9 when you only worked 16-hour shifts. Your reaction time was much faster. You were reacting in only 283 milliseconds versus 336 when you worked for longer periods of time. However, your slowest reaction time was much slower in the 24-hour group, reacting at about 683 milliseconds versus only 509 in the 16-hour group. And then the sleepiness rating was higher after working a 24-hour shift versus 16. Something that I found very interesting in this study is that, again, significant medical error increased by 70% with this 16-hour shift versus the 24-hour shift. So we're seeing a theme here that when looking at the raw data, you do have a significant increase in medical error when you decrease the shift length. However, they noticed again in this study that when you had these lower shifts, the 16 hours, you had up to a 30% greater increase in your patient load. So they once again adjusted for patient load and found that the medical error rate actually decreased in the lower shift. So once again, it seems like we're starting with shift length maybe being a significant factor for error, but it's really pointing more towards patient load, which I thought was very interesting. So overall, what is the effect on resident education? We've talked a lot about patient care, wellness and safety. We talked about resident wellness and safety, but we're all here to learn, right? So I looked at this systematic review of 27 studies taking place between the years 2010 to 2014. And they showed that, again, duty hour restrictions had no impact on patient care or resident wellness. However, residents rated that these duty hour restrictions negatively impacted their education in 64% of studies, and there was no impact in 36% of the studies. So this is really the first time in any of the research that I had done so far that we're seeing a greater than majority impact on this, and it's on our education. We're spending less hours in the hospital. We are seeing more patients as we learn, but we're having less continuity with our patients that we have. And this really could be impacting the way that we learn. Interestingly enough, of all of the proposed methods to decrease duty hours, night float was least effective with regards to resident education and wellness. Excuse me. So despite night float being a really popular and common way to decrease that Q3 day call schedule within the hospital setting, residents seemed to like that the least in terms of their wellness, and they also felt that their overall education was impacted from a didactic standpoint. You're not around for the didactics during the day. In our particular program, when you're working nights on the PICU, you miss both morning report and noon conference. So you are missing a lot of formal learning opportunities, although it can also be argued that being in the hospital at night kind of triaging things by yourself, of course, has a positive learning experience in and of itself. But just based on data alone, the night float was kind of the least effective. So something that I really appreciated while I was going through all of this is that these studies kind of look at these things independently. They're breaking them down between resident wellness and patient wellness, resident education and patient care. But this is really a complex system, and all of these things are interrelated. Medical error and patient safety, patient care, resident education, and resident wellness and safety all depend on each other. If you have residents that aren't well or aren't being kept safe in the program, they're going to be unable to care for patients well. But on that same token, if they don't get a good education, they're not going to be able to care for patients as well either. So all of these things are really relying on each other. And I think one of the flawed methodology of these studies is looking at them independently. Here you can see pictures of Lola and Pug. Lola looking extremely sad on the care that she got from me when I made her go out in the rain early one morning before work. And Pug is showing you what can happen when you have some unhealthy coping mechanisms. If your resident wellness is poor, he's drinking his little doggy beer while falling asleep in bed. We don't want either of those things for our patients or our residents. So ultimately, there's no easy solution to this. Our program is an example of limiting 24-hour shifts and extended calls and substituting them with night floats. When you're thinking about it in terms of patient load in and of itself, one thing that you can do is increase hospital staffing to disperse the workload with AAPPs, which is exactly another thing that we've done in this hospital. I kind of wanted to take this time to open the floor up a little bit to the current residents and the attendings that were residents back in the day, and maybe ask if you see any alternatives, if you like the way that the hospital is doing it. Dr. Mullet specifically, it was brought to my attention that the PICU changed their in-house staffing shifts from 36 to 24 hours. I was wondering if you could maybe touch a little bit on what the thought was behind that. Obviously, I picked this topic. It can be a little bit polarizing, so I was hoping to get everyone involved in a little bit of a discussion here. And then I have a little more before I finish up, but I was hoping we could talk about what you all thought appropriate alternatives would be.
Well, nobody jumped in there real quick, so I hit the unmute button. A very nice summary of a lot of very sentinel papers that had to do with sleep deprivation and functioning in the medical environment. It's interesting, the military has been quite involved in this research. From Walter Reed, they actually have a sleep research center that looks at fatigue-related injury. And basically the term for that is friendly fire, and has to do with psychomotor vigilance and all. And there's a couple researchers that are very big in this, Alison Brazier, and then there's Mary Carkston, who's from Brown University, or sleep neuroscientist. And the circadian biology of individuals is obviously different, and some people are more tolerant to sleep deprivation than those that are not. Their circadian clock is wired differently, and Alison Brazier has done some genetic research with the special forces from all the different branches of the military, and found that people become special forces who do a lot of night ops because their circadian biology is more primed to do it. Their psychomotor vigilance is better, and they have very specific genetic composition. So that's not going to really work. We're not going to do genetic testing on every resident that comes through and say, hey, you really do well doing 24 hours, and hey, you would not do well doing 16 hours. But people probably branch into different areas of medicine because they're more tolerant to sleep deprivation. Surgical versus non-surgical, intensive care versus otherwise. And but there are solutions, and the NFL does this, and there are things called military energy gum that is used, that every soldier carries in their pocket. And actually, the NFL uses it as well. It's a highly absorbable sublingual caffeine. But one of the things that works best most often, rather than adjusting shifts from 16 to 24 hours and 24 to 16 and all this different, are called naps. Remarkably, if you're allowed to take a nap in the afternoon, a power nap, your psychomotor vigilance goes up for 4 hours. And so don't come to my office in the HSC at 2 o'clock in the afternoon if I'm sitting there, because my head's probably on the desk and I'm doing a power nap. But we have this Western society that doesn't believe in siestas, right? We can't siesta in the United States because then you're lazy. I would say to you that if I were to encourage anything, it would be called naps. Just take a nap in the afternoon, less than an hour, 30 to 40 minutes in maximum. Get up, go out and get some sunlight, stand by a window, rather than manipulation of 24 hours versus 16 hours based on retrospective data that does not take into consideration that the chronobiology of individuals are different. Some people are night owls and some people are larks. I'm an owl. I like to stay up. How about you guys? Are you larks? Are you owls? I hate the early morning. It requires 2 cups of coffee with high caffeine in it, sometimes double shots. So that's just my editorial to this.
Thanks, David. All right, Hannah. This is a really interesting topic, both because it's important and impacts all of us, well, certainly all the residents and some of the faculty, the ICU doctors, mostly. I'm very aware of the 24-hour shifts. So 2 weekends ago, I was on faculty night float for PICU. And I recall, after my Saturday night shift, in rolls 3 residents and 2 APPs at 5:50 a.m. And one of the residents is on a 24. And I was like looking at this like, wait, why do we have 5 people here today with one of them on a 24-hour shift? Why don't we just have 4 and tell that resident to come in Sunday evening? And so I do think we have options if we want to change our coverage model in the PICU on Sundays. It's interesting, but as you say, the night float is unpopular, and I didn't really know that. I can see why. It's kind of hard to shift your biology so much. And so the interesting thing is, should we go to a modified Q3 call or Q4 call where you're on once every third at night in a night float sort of way, a 12-hour shift? But we'd have to pull residents off of electives. And so it is really, do you want to work harder for a month on the PICU and have your elective months call free, or do you want to have night duties spread out through more electives, through more times in your residency career, I guess, is the question. Food for thought, right?
Yeah, and that's kind of how I feel. I mean, I'm of the park where I'd rather work harder in the period that I'm to work, and then have my electives to be a little bit more of an enjoyable time. It's interesting what Dr. Thomas said about naps. If you look back at some of the older duty hour recommendations, there's actually a clause where it recommends getting a certain X amount of sleep. That doesn't necessarily exist anymore. And I think that's a good segue into looking at how some other countries do duty hour regulations. So I looked at Europe specifically. So the European Working Time Directive became law in 1998, which is kind of around the time that ACGME started implementing duty hours. So theirs is a lot different than ours. So their maximum work week is 48 hours per week versus our 80. They require a minimum rest period of 11 consecutive hours per 24-hour duty, which is actually a little less than ours. Ours is 14. They require a minimum rest period of 24 hours per 7-day duty, or 48 per 14-day duty, which is very similar to ours. A minimum of 4 weeks of paid annual leave, which is what we have. And then they have this interesting clause here, a maximum of 8 hours work in any 24 hours for workers in stressful positions. I couldn't necessarily find what constituted a stressful position. I think I'm in a stressful position often. So I would actually be interested to see what constitutes that in terms of this European Working Time Directive. And then they require a 20-minute rest period per 6 hours worked. So this kind of alludes to what Dr. Thomas was saying, that you actually have a required rest nap period That brings on a whole different set of complications in terms of how you actually get a required amount of time of rest while you're at work, especially, if you're the only senior on, if you're on by yourself, if a patient is decompensating during that time period. That's a little bit difficult to regulate, but it's definitely an interesting concept. And like Dr. Thomas said, it's a little bit more conducive to accepting kind of everyone's needs versus looking at these different shifts that are really difficult to actually implement within a hospital system. However, despite these more stringent working regulations, a study done in 2014 showed that only 6 of 27 European member states were actually compliant, and a lot of them did go over on their duty hours. An interesting side effect to having more limited duty hours would mean that residency typically is longer. A study that I found showed that the average length of pediatric residency in Europe is about almost 5 years. They range anywhere from only 2 years in Russia to up to 7 years in some other countries. So there's a lot less standardization across the board there. And there's also a lot less standardization in terms of time spent in medical school, time spent after medical school. So you come to the USA where things are a lot more regulated. There are 2 other countries that I looked at. There's Canada, which actually doesn't have any duty hour regulations, which I thought was very interesting. And then Australia, which operates a lot more similarly to how we do with the 80-hour work week. We're going to be frozen again for a couple seconds.
So I wonder what Chuck or Autumn could share about the effect on attendings on hours now that you're doing in-house. And I also wonder what the ED literature is, because people who work in the ED chronically are working these funky long shifts that change their sleep. I guess maybe Heather Claudius addressed some of that changing from day to night. Just wonder if anyone knows.
So I will say, Dr. Moffitt, I did look a little bit into how there's duty hour regulations for residents. And as they get more strict, they kind of almost become less strict for attendings. And you do have, especially in the surgical specialties, where you have attendings working longer hours than you have residents. So that is a significant impact of all of this, is that you have all of these things coming in to protect residents. But then as you get further in your career, it's kind of lost that you're not being protected with these duty hours, despite some of the things that we discussed with sleep deprivation, et cetera, still being very relevant regardless of your age. I don't know if any other attendings here have anything else to add, but I did come across that in my search, that it is kind of an unforeseen side effect of regulating residents' workload so much.
Well, I've wondered about that for like OBGYNs who go out into private practice and all of a sudden they're taking a bunch of nights and delivering, and how safe is that? And that still happens very frequently in private practice.
It does. And that's kind of one of the arguments for why the 24-hour shift, or kind of learning to work under these more stressful situations, exists, because even when you're protected as a resident, you are no longer protected as an attending. So is it necessary to learn how to work under these conditions now so that we can do it later when we don't have a governing body saying that we can only work for so many hours a day?
So this was actually a topic that came up way back when, and I started my residency in 2000, where it was 24 plus the next day. And by 2003, some of us older residents were like, the interns have it too soft. They're only doing 24 hours. But it was a real concern that both from the residency director, that there were not enough residents to cover all the clinics and all the shifts. So there was a manpower issue, but more importantly, as you pointed out, once you become an attending, there is no protection about your work hours. You put in whatever hours are needed. And some people, I know some people who basically worked 2 jobs. They did their regular, and then they would do ED on the weekends. So they were easily racking up an extra 32 hours a week working in emergency rooms to help pay down their loans. But it was a question of both the training. If you weren't, as my residency director said, if I can't trust you in the middle of the night, how do I know that you'll be able to take care of your patients when you're out on your own? So that was a real concern back then. And I was fortunate that actually we had residential housing less than a block away from the hospital. So there was no excuse for showing up late or no worries about motor vehicle accidents on the way back home.
And thank you everyone for your input on that. It's I think important for us to hear everyone's perspectives, especially now that we kind of are more protected, which of course, as a resident now, I appreciate. Just to kind of finish up here before I open up the floor to any more discussion, conclusions that I kind of came to from this is, of course, there's a lot of conflicted evidence and there's no perfect solution. You can look at all of the individual factors, you can bring them all together. At the end of the day, patient care and resident wellness and resident education are all things that we're striving to meet at the highest degree. And there isn't a perfect solution that exists. Unfortunately, night float, being one of the most common solutions, is least favored for resident wellness and education, despite maybe seeming like the quote unquote perfect solution. And then another important conclusion here is that of all of the factors that we looked at, resident education is the one that's most significantly impacted by decreased time in the hospital. And then something that I found the most interesting in all of this is that it seems like workload in and of itself plays a larger role in medical errors than shift length. And I think that's an especially interesting thing to discuss right now, being where we are in the pandemic in terms of having issues with hospital staff kind of across the board. It's another thing that doesn't have any sort of easy solution. So even though this is a polarizing topic that I think all of us have our opinions on, I really just wanted to give this sort of objective data-based overview to really bring to light all of the problems that are coming from kind of both sides of the argument. I wanted to thank Dr. John and Dr. Lynch. They helped me with this presentation. They heard it yesterday and gave me lots of helpful feedback. And they've also actually both been really helpful to me throughout my entire time here at residency. They're probably two of my strongest mentors who have been there for me through a lot. And I'm so grateful to have them both in my life. And I am thankful to all of you for listening and to the rest of the attendings and my peers for being there with me for the last 3 years. I know I'm not gone yet, but I will take this time while I have everybody's ear to say that I have had the most wonderful experience here. I've learned so much. You guys have really given me the opportunity to step up and into my doctor's shoes. And I just feel like this place as a whole has given me everything that I've dreamed of, and I could not be more grateful. So I would like to say thank you so much for all of that. And Lola and I would also like to wish you all a very wonderful holiday season that we're coming into next week. Thank you all again so much for listening, and hopefully y'all have more to add, because if not, we're gonna be done 15 minutes early.
Hey Hannah, it's Colin. I just wanted to, I was wondering if, through your research at all, if you ever came across anything that kind of looked at duty restrictions in other professions, such as like truck drivers or airline pilots, and how they kind of compare to us, because I think they have a little bit more federal regulation, whereas I don't think we fall under the same umbrella.
We do not fall under the same umbrella. I did not look into that too closely, but that's a really interesting concept that you're bringing up. I'm sorry I didn't look into it myself. But I think that's a great point, because, and it's kind of that model of like how they compare hospital safety versus airplane crashes, and how different things look into different ways to prevent these errors, and how hospital systems aren't always the best to do that. So that would be a really interesting thing to secondarily look into. Sorry I didn't look into that myself.
So Colin and Hannah, if you want some really good reading, it's probably several thousand pages, but it's David Dinges, Dinges. He works for the Department of Transportation. He works for the Federal Aviation Association. And if you look at how they manage the pilots and how they manage the truck drivers, how many hours they can be in the road, truck drivers have to have sleep screenings, so do pilots. So it's very regulated at the federal level. And for my editorial addition is I think medicine has done a really bad job of framing the issues. They've taken a lot of data that is very questionable from the past, and they have decided to provide a treatment group without really having good endpoints to decide what was most effective, and made global decisions. And a lot of this is a good lesson in that the political environment over the Libby Zion case really dictated what happened to the residency hours, and the science is really kind of retrospective analysis. And you only gave the one paper with 2021, which was from Pediatrics, where they used the psychovigilance testing, and which is more objectified data. And it's interesting that the military, the NFL, and college athletics is more ahead of this than is the medical societies, which is another very interesting fact. NFL players, college athletes have performance recovery sleep requirements. They do. They actually nap. They have circadian shifting biology protocols and all this kind of stuff. So a lot of it was made off of political just pressure.
And then I'm looking here at the chat a little bit. So Dr. Kidd asked if any of the studies look beyond resident self-report for educational impacts. They actually did. I didn't find one that looked specifically at board pass rates, but I looked at one that examined performance of residents on standardized testing after a long shift versus after a restful sleep. I think this goes without saying, but residents who had a more restful sleep performed better on their exams. I was really looking to see more of a long-term educational impact myself, Dr. Kidd, that I didn't find. Maybe I was just looking in the wrong place. But I did think of that, and I did see that there are short-term implications for performance based on acute sleep deprivation, but I didn't find any based on more of a long-term sleep deprivation. Jake says here, one difference between resident and attending work hours is attendings have the options to take jobs requiring less hours and negotiating their shifts, where residents do not. I completely agree with Jake, kind of in a system where obviously attendings have a lot more autonomy. I think we do need that governing body. I think it does protect us. And I would be in complete agreement with him. Vince says there's not a one size fits all solution. 24 hours may be better for managing patients with higher complexity to avoid many handoffs. The studies talked about workload, but not necessarily complexity, which is also an important factor. I completely agree with that with you, Vince, as well. I did look at one study where they looked at if the number of handoffs was specifically impacting the increased rate of medical errors. And then I also looked to see if they controlled for the type of handoffs. About 50% were IPASS and about 50% were non-standardized handoffs. And after accounting for different confounders in the data, they found that an increase in handoffs wasn't actually increasing patient error. But I agree that it's obviously something we've all experienced. Increase in handoffs certainly leaves room for miscommunication. Dr. Neild, I will message you about that. I just said about the quality and handoffs. I love a good nap pod. And Janice says, as we look to offload work to APP, should we also be cognizant of the same principles as they apply to APP shifts? I think so. I mean, if we're protecting residents, then other people should be protected as well. I do know that APPs typically don't do 24-hour or extended shifts. I could be wrong in saying that. If we have any APPs on the talk that could enlighten me, but I think that the APPs that we typically work with are doing the more standard like 10 to 12-hour shifts. But I agree. I don't think that we should throw one subgroup of people under the bus to protect another group. I think that's important. You know, we're all a team. If one half of us is coming in to help the other, then I think that it's important to make sure that those people are receiving the same kind of help and protection. Also, I do take naps on my 24s. I sleep on the couch in the resident workroom when everyone else is all around me. And I always say my eyes are closed, but I'm here to help. So I'm a big believer in the nap.
Let me comment about, I didn't hear you really make the point, but I think there is a difference. So like nurses, bedside nurses, very task oriented, minute to minute, doing something the whole time, very dense. Task list, they are limited to 16 hours by Joint Commission. 12 hours is their standard shift, and no more than 16 hours. Residents, and this kind of gets to Kathy's question earlier, residents are kind of next level, like a little bit of downtime. You can go to the workroom, sit in our lazy boy, rest your eyes a little bit, but you're likely to get paged in 15 minutes. I'm speaking about the PICU experience. And so you only get a little bit of short downtime. Maybe you get an hour in the middle of the night. I don't actually know. You guys have to teach me. And then to her question about faculty, when the PICU faculty went in-house about 8 years ago, we only had 5 faculty. And so we were really, we actually voted on how we were going to split the call. And I was the division chief and medical director at that time. I was like, well, no way we're doing 36 hours in-house like our out-of-home call schedule was, like at-home call schedule. And so we voted a bunch of different night floaty, shift worky schedules. And, we, the group, voted it down really. And we ended up keeping our same home call schedule for in-call duties. But really, when we were in-house, at first, at least, it was like, hey, kind of pretend I'm at home. I'll be in the call room. I'm here just for, major issues or disasters. But I'm not here to do minute-to-minute work. And as we've added faculty, that shifted over time. And as you all know, the neonatal staff just went in-house. And so we're all figuring out that kind of faculty level nighttime duties. How many faculty do you need to make it be humane? I don't know, maybe, for a career, a 30-year career, right? So we gotta think about all that stuff. And so it's definitely a work in progress. And since we have the applicants here, let's bring this up and talk about it, right? We don't have night residents in the NICU at night, right? If that hasn't changed recently, but I did hear that Tricia did the NICU night float elective recently because she's interested in neonatology and there's more autonomy at night. So I'm actually, as a chair, I'm definitely in favor of like not having 24-hour shifts, but my phone is blowing up from the PICU faculty text group. Like they think that there is a role for a 24-hour shift still. I think that's debatable, Hannah. And I see Dr. Neal invited you to write a review article on this. If you can draft it out in the next 5 weeks, yeah, good luck. But we did record this. We are recording this, as you know, and so you can use all the comments here. So I think this is a work in progress. I think we have the option if we as a program want to get rid of 24-hour shifts. I think we as a program should, right? I think that's on the table, but it's all in balance. And how and what do we want to? How do we want to piece the coverage out? And what are the benefits? I invite the program to rethink things every year. We should rethink it every year.
Perfect. That was my goal. Get everyone thinking a little bit more about it.
And if you don't mind,
yeah, go ahead, Dr. Lefebvre.
Oh, sorry, I jumped in front of Katie. Sorry. First of all, Hannah, that was an amazing discussion of the literature. I think you couldn't have done it more justice. I think the key point to bring up is if there was a better solution that was easy, somebody would have thought of it, right? I think the hard part is getting this intense experience in a short duration of time of learning how to be a doctor and trying to do it without hurting people's sleep. I think a lot of good things were brought up. I guess one thing we're not good at measuring, and Katie can correct me from a scheduling standpoint, usually for our seniors, there is a limit, I would say, a range of 6 to 8 24-hour calls per year that would be asked of our seniors. And typically, and not all the time, but typically, not only is there a post-call day, but usually a day off is built in to follow post-call days under most circumstances. Not all. We always meet the 24 hours after, but oftentimes we're able to give that bonus day off. I don't think it's perfect to have 24-hour calls. I do think night shift and night float is also very challenging for flipping back and forth for some residents. Living nocturnally, trying to function during the day, the impacts of those is really trying as well. But I don't think you could have done a better job of putting this out there. I appreciate you, Hannah. This is about as well done as I think anybody could have done it. So
thank you
for educating us and helping us think about this every year. I think, if you guys want to do 5 years of residency, we can go with the 40-hour work week. Chuck, we might need a little bit more funding for that to pay for years. But hey, that's another alternative to kind of cutting back the hours is you training more time. But is that right or wrong? No, it's different. And I think you really gave us some great thoughts. So thank you so much.
Thank you.
Yeah, and I don't know if Dr. Ferron is still on here. He trained in the US, was an attending faculty in London, in England, Bristol, I think, and then came back to the US, and after 5 or 6 years there as an attending, and when we were in the process of hiring him, I called his division chief, and she still spoke of him as if he was like a resident. Like, they have a very long, like, graduated experience, a lot of years in training. Like, after 12 years of being a peds registrar or something, now you can be in ICU, and even 5 years, 6 years into your ICU attending hood, you're still suspect. And so it's just interesting to reflect on maybe some of the culture that happens if you limit work hours, and to your point about that data about 4.7 year-long peds residencies. Yeah, so, all in balance.
Thank you, everyone, for that wonderful discussion and adding so much to the talk. I will say, if my opinion counts for anything, my favorite system that we've done so far as when I was a resident in terms of working on the wards is what we did my intern year, which was 1 week of night float and no 24s. It eliminated the extended shift, obviously, and it also eliminates your time spent on nights. I personally think it's a little bit easier to flip back to days after just 1 week of nights. Like, once you're on for 2 weeks, it really messes with your way of life. That was my personal perfect solution. I know everybody would have a different opinion. And I think that, I don't love a 24-hour shift, but I think that learning to do one is important. I'm not fully advocating to get rid of them for every place. I think doing them in the PICU is a good learning experience. But I will say I did like that first year ward schedule. That was my favorite solution.
Hannah, that's exactly what I was going to actually comment on. I think, especially with applicants here on the call, I think something as a freshly graduated resident, I really appreciated about our program is the flexibility that has changed the scheduling based on resident preferences throughout the years. So Hannah kind of just gave a great example of that. I personally would fall into the same category. There are multiple people on here who have seen me at the end of a 24, and I do much better functioning nights and switching back. But that isn't always the same for everybody. So I think I've seen multiple examples where we had preferences of a certain group of seniors, and then that last group kind of graduated out. The new group had different ideas. We switched them and kind of went with what the current group was going for to decrease the total amount of 24s and manage that the best that we can. So I just really plug to the program for saying, like, you're doing what you can and trying. And I think especially now, seeing all of the chief resident chains across the country, the number that we do here is considerably less than anywhere else that I'm seeing scheduling questions coming from other programs. So I would also say kudos to those who came before us and built it this way so that we can have that opportunity too.
Thank you, Hannah. Excellent grand rounds.
Thank you all so much. Have a wonderful day.
Have a great Wednesday, everybody.